All right. Okay. So, all right. So yeah, thanks so much for joining us, Dan. So Dan's a retrieval consultant with MedSTAR and also is involved in some coordination from a retrieval aspect down in South Australia. And, we certainly saw from Josh's talk about RFDS out of Broken Hill, some of those sort of huge distances they have to cover and what's available at the other end when you arrive. So you're really looking forward to it. And over to you, Dan.
Great, thanks very much, and thanks for the privilege of speaking today.
Yeah, no problem.
I want to speak about a night coordination shift that I had a couple of months ago. If this meeting was next week, I might have talked about my coordination shift I had last night, which has given me a few more grey hairs, but that's the way it goes. So we coordinate 24/7, 365. The calls come into the EOC. This is a picture from a couple of nights ago. You can see we've just moved into this office and we need another lick of paint back here, but these are some of our nurse retrieval consultants who take the first calls from the country GPs, and if they're big sick or they've got questions, then they flick them through to us. So as the medical retrieval consultants, we do more than 28 days and less than 28 days old, the retrieval consultant neonatologist does. And we count, when that call comes in at 30 days, we definitely count how old they are. So at the moment, we're up here during the day and then for a few hours at night. And then when things settle down, we go home. And then this is my desk where I'm sitting at the moment, and we coordinate from home. Okay, so what do we do? The general service does about 2,000 missions a year. That's not including the pre-hospital, the IHT work with RFTS that we oversee. That's the MedSTAR team's jobs. We do a mixture of inter-hospital and pre-hospital with more IHTs, and we have a bit of a balanced rotary fixed-wing road mix. The kids service do slightly less missions, and they've got a neonatal and paediatric case mix. Where do we go? So we're below that line. We're below this one. We do go up to COVID PD, and then sort of north, it's as you probably heard this morning, I missed the talk, unfortunately. They've got the Broken Hill response from RFDS. They've got the Central Ops RFDS, and then the Port Augusta RFDS have a Commonwealth response sort of out here. We had a really bad trauma last night in around here at Lee Creek, Copley, which Steph Missoula was up doing bringing back 3 patients from that one. So that was an example of how far we go. Where do we go in the rotary asset? That's our rapid response zone, and that's a picture of the helicopter on the roof at the Royal Adelaide, and that's sort of you can see how far we can get to in one of our 412s. What do we have? Usually we've got 2 helicopters online, depending on maintenance and all that sort of stuff, and what the SAPOL, the South Australian Police Service, need one for. And then we've got a contract with RFDS, and if we need to go outside that rapid response zone, then we'll jump on one of their planes and go. And sometimes we've got the PC-24. Okay, so a night coordination shift. So there are more experienced people out there than me. It's not my first rodeo, but it's not my second rodeo either. But I do like this cartoon that we're always learning, and there are a lot more experienced people out there than I am, so I'm happy to take feedback. Okay, so I came on at 6, got the handover from the day MRC. We had 2 kids teams out, we had a general service out, and a special operations team, ICP, was in a helicopter coming back from Wallaroo. The hospital system was struggling. We were ramping a lot of the hospitals and the EDs, so that means the external triage with patients and with ambulances on the ramp, and our ambulance service was stretched. But we did have assets available, and the plan from here was we had a non-invasive transfer to come back from Port Augusta. So what do we have on the books at that point in time? Down in Mount Gambier, we had a small bowel obstruction in a 75-year-old gentleman. We had a mental health patient at Wowler, an 18-year-old female who possibly could stay there and was going to get a review, a telehealth review. We had an unstable T-spine, T4 fracture in an elderly gentleman at Port Pirie who needed to come down to the Royal Adelaide for spinal admission and review. Had a 14-year-old girl with a DKA, which the kids team had gone to. Her pH was 6.85, and they were on the way back, and that was largely going well. We had an 88-year-old female had a PEA arrest at a smaller hospital north of Adelaide, and a general service team were going to pick her up and bring her to an ICU in the city, but things weren't looking good for her. We had a first presentation of seizures in a 3-year-old boy at Cleve over on the Eyre Peninsula. A kids team was being sent by Fixed Wing. We hadn't yet received the sit rep from those guys. We had a possible quarter equina at Wallaroo, and the SOT was going in the helicopter to facilitate that rapid transfer for urgent MRI. Had an old chap in Kingscote on Kangaroo Island who'd fallen, had raccoon eyes, and needs an urgent scan, those CT scanning facilities on Kangaroo Island. And we had the non-invasive transfer at Port Augusta. The day MRC had been trying to wean off the NIV, but had been unable to do that, and they had some rising drops, so we probably needed a team for that. Okay, so I'm in the hot seat, and our first case was an activate. So the call comes in from the 000 caller, and if it hits certain criteria in our medical dispatch priority system, then it'll get flipped over to us to send a team. We can potentially value add. This is a 56-year-old who'd fallen from a ladder at Woodside, and the 182 MedSTAR general team went in the helo. The first sit rep from the SAAS crew was he was unwell. He was decreased conscious state and potentially a left-sided tension pneumothorax. They put a needle in and had cool peripheries. The sit rep from the team was, he was GCS 6. They were going to do an RSI, bilateral finger thoracostomies, give him some red cells, and get them moved into the trauma centre. So my role there was to help the team if they had any questions, but then to inform the trauma centre. And I think the ED consultant on at the Royal Adelaide that night was Associate Professor Andrew Pearce, who's our clinical director at MedSTAR. So a little bit of extra pressure for the team handing over in resus. So the new plan there was to send the second night general service team to Port Augusta. Second call that came in was from Mount Gambier, so down in the southeast, 47-year-old with pneumonia and empyema. They weren't too bad. We can put them through for a flight nurse only transfer. Third case came in from Yorktown. As you can see, it was a bit of a chest pain for investigation, bit of a mild trop rise. Cardiology will lock them tonight, so we can put that in for a flight nurse transfer. Case 4 came in just after 8, a 3-year-old from Broken Hill, and the ED locum there said, look, I'm calling for advice and for transfer. We've got a massive pleural effusion on chest x-ray. So Broken Hill is a bit of a tricky zone. It's a long way away. If we send a PC12, it'll be a long time. And then sometimes it's NETS, sometimes it's us. And then, most importantly, how sick is this 3-year-old? So that was the chest x-ray that we got sent through from the locum at Broken Hill. And you can see, obviously, the whiteout. Yes, some tracheal deviation and possible hyperinflation of the left lung. So, this is not a case that we can sort of push off and argue turf. We need to crack in and help the team out and help this 3-year-old. What have we got? Well, febrile, but holding their own, pretty good hemodynamics and good oxygenation, and the background of some recent gastro, COVID negative, been given some antibiotics. So we added some further antibiotics, and we're confident in PICU at the Women's and Children's, and there was general agreement to hold off a drain as there was no clinical signs of tension at the bedside and she was looking like she was okay. But Broken Hill Base Hospital had come up with a plan and had mentally sort of prepared to put one in if she got worse. So who was going to move her? We got NETS on the line, and they said that they were pretty short on, and that had a bit of work on. They could go, but was going to leave them really short and would prefer that if we go. So with our interstate jobs, we sort of run that up the chain, and the head of unit coordination, Ellie, said, yep, crack on, we can get this done. So we got Gen Peds and Women's and Children's, PQ on the line. Everyone agreed to come down to Women's and Children's, and we inquired about the PC24, but they had 2 paediatric transfers planned for the next day, and if we took that asset, then we would be deferring those cases. So we decided to task one of the night kids team on the PC12, and we ensured they took their ultrasound in case they needed to pop a drain in. All right, so that's moving. Case 5 is a diabetic foot ulcer in Barmera. They had been given antibiotics, and we'll get them down hopefully in a few hours. A call came in for the retrieval coordinator, neonatologist, and it was from the Lyell McEwen Hospital, which is one of our spine hospitals in Adelaide. This few hours old boy was born with respiratory distress. He was intubated, now in CPAP, and they weren't quite sure whether or not he needed cooling for hypoxic ischemic encephalopathy. And that discussion with the RCN resulted in the kiddie staying at Lyell Mac, but call back if they're worried. Okay, so case 7. So I'm home by this stage, ready to tuck into my dinner, and got a call from Port Lincoln Theatre. So Port Lincoln's over there on the Eyre Peninsula, smallish hospital, no HDU. And the first line is that we've got a PPH now in theatre, and we're requesting a retrieval with an activation of MTP. So we've got a 21-year-old who's delivered today, now Para 1, who's was failing to progress, so had an emergency C-section under spinal, and she was going okay, but then dropped her bundle in recovery, given crystalloid, metaraminol, but now she was also hypoxic, and she dropped her hemoglobin significantly, and we're their first call. All right, so we've got of an A to E. She's intubated, ventilated under GA. Sats at 54% on an FiO2 of 1. She's on a metaraminol infusion for a blood pressure of 78 on 28. They found a tear in the posterior part of the uterus, but they were concerned that there was not enough blood to account for the clinical picture. She was getting some Synto, and then infusion was about to start. They've given some TXA, they're about to give some TXA, and they're about to start some O-neg blood, and they had thoughts about an adrenaline infusion. So my thoughts at that point were, this is game on. We need to stay calm, we need to communicate well, and we need to help these guys out. So, yep, agreed. Let's try and do hemostatic resus. Let's try and be balanced there, but let's move to bread cells first. And she probably does need an adrenaline infusion if we can't maintain perfusion. Let's continue that PPH management. And one of the really helpful things as a part of our coordination system is that we can get multi-party phone link-ups. So while we had the GP anaesthetist on the phone in Port Lincoln and me at home, the nurse retrieval consultant at EOC in the call centre, we can then link in the obstetric consultant from Flinders and get their advice in real time while everyone's on the line. And their advice was, yeah, consider a Bakri balloon, and but agrees with how things are going so far in terms of the surgical management of this case. So I checked our blood app. We've got an app on our phones that we can look at the blood resources around the state. Port Lincoln, this was, I took this screenshot a couple of nights ago, but that's what they had then. I looked at that and I thought that an MTP could help. So we've got a process where we can ring up the Royal Adelaide and the transfusion services get an MTP ready for us. If we, sometimes we go and pick it up from just under the light pole there at the ambulance entrance. But in this case, because we're going by Hilo, they landed on the roof, which is just up there, the helipad. You can see on top of that picture. And then a hot offload, onload with the MTP, and off they go to Port Lincoln. And then we tasked them to take the obstetric specialty pack, which we carry a few extra uterotonics and a few other obstetric stuff. All right, so what are we thinking? Hemorrhagic shocks at the top of our list. Amniotic fluid embolism's a chance, anaphylaxis, maybe PE. It's unlikely to be local related, I thought, or we thought. And then we run through the 4 T's of the PPH as we learn so many times for our DIP farm exams. So at one stage, this is about sort of 15 minutes after the first call, we were trying to work through things. The first call came in on the line for about 15 minutes, and we were trying to work through a few issues, and we asked for an update, an ADOE update, and the GP anaesthetist says, so we're intubated, SATs are now unrecordable, the end tidal CO2, that should say CO2, is 17, and I asked if we had output, and they said, actually, no, we don't. So but we ended the call, and they commenced CPR. So this is a tough moment. I'm sitting at home at my desk. We've got a 21-year-old obstetric arrest under CPR in Port Lincoln. Our team's still an hour away by flight. We've got a very capable team in Port Lincoln, but yeah, it's not a great place to be. I had a chat with the intensivist at Flinders, who would be receiving. Flinders is again one of our spine hospitals and is the major obstetric centre. If we were able to get Ross, she was going to go there. And I asked his opinion, what were we missing, what should we be doing, and he just reinforced the basics. Said that do whatever you can to get her here, and we'll pull out all stops if we can get her here. And obviously just confirming if they had a bed if we get Ross. So I called back about 25 minutes later and to see how they were going, and they had Rosk. They'd given 2 doses of adrenaline. The blood pressure is now 48, and my advice was to continue volume and try and get some more perfusion by turning up adrenaline and potentially start some NORAD. And inform them that our team was on the way. So next call comes in, and it's a 56-year-old in Murray Bridge, which is close-ish to Adelaide, and I had to sort of give advice to the Port Lincoln guys, but then take this next call. And we've got a GCS3 in a 56-year-old lady. She was drinking alcohol and she's on multiple sedatives, but she was witnessed to sort of slump down, and they were ringing for advice and transfer this patient. So we felt it was probably sort of polypharmacy and alcohol related, but we couldn't rule out intracranial badness. She needed an urgent scan. Looks like she needed to be intubated, ventilated, and neuroprotective measures instituted, but we didn't really have a resource to transport them. We spoke to the state duty manager. There's potentially an ICP that could go up from Adelaide, but that would be a few hours. And luckily, the SAAS Chief Medical Officer, James Dobe, who is also a MRC with us, was logged in to his vehicle, was because the state was struggling with resources and ambulance capabilities, and we called him and said it was a bit off piece. And I actually ran this one up the chain about a similar time. AP Andrew Pearce rang in and asked a question about something, and I said, what do you think? Do you think I can task James to go and do this? And he said, yeah, crack on. So James went out, went to base, joined an SOT, and they went to the Hilo to Murray Bridge, and then on to, actually, I think it was on to Royal Adelaide, not Flinders. Okay, so that one's going in an okay direction, we think. We call back to Port Lincoln and we get an update. So now they think the estimated blood loss is around 2 to 3 litres. Battery balloon's in. I've got a general surgeon in packing the abdomen, but stats are still 77, and title's okay on a fair bit of inotropes. They've had some filling, they're giving some TXA infusion, they're trying to keep them warm, and the coags from earlier show that she's got a coagulopathy, and they're trying for an outline. Spoke to the critical bleeding hematologist. What else should we be doing? We've got some FID-CONC. We asked the transfusion to give us some FID-CONC with the MTP, and her advice was that we should give this if we think she's got amniotic fluid embolism. So our team arrived, and our very capable and very nice UK registrar's opening line to me was, "Oh, Dan, this lady's quite sick," with NORAD and adrenaline at 50 each. So he had a good look at her and thought that she had a right main stem intubation, which I was kicking myself that I hadn't gone through that with the team over there. But he pulled that back, and with that, her oxygenation did improve. They gave some more volume. They got an outline in, and she was cold, and they started warming her. So the first gas that we got with our team was a pH 6.86 with a lactate of 13 and hypocalcemic. And after some treatment from our team, she was a bit better when she arrived at Flinders. Total products for her between the Port Lincoln team and our team were, as you can see there, and she was actually off the inotropes by the time our team got her into ICU at Flinders. Unfortunately, the night keeps going. Got a call from Mount Barker saying that we would like to transfer a lady, male with pancreatitis, borderline blood pressure, and can we review, see if they do need treatment, need transfer. But he looked all right and could probably come down in the morning with when we had an appropriate resource. Got the sit rep from the team at Port Augusta. This man was now off NIV, but they're going to set up for BiPAP en route if he needed that, and he was going to go to the Queen Liz ICU directly. And then another call came in for the neonatologist. Burnside Private Hospital had a 3-year-old in respiratory distress, so they needed to call the on-call kids team to come in and go to that one. Got the sit rep from Broken Hill. Sorry, no, this is not that one. This is the sit rep from Murray Bridge, and that one is going okay. She's quite flat, quite deep, but no major dramas, and they're going to package and move. Got the sit rep from Broken Hill. This child's elevated respirate, but looks okay. They were not particularly keen to put a drain in. We thought that was safe, and we had a plan for decompression if required, but they were going to transport as is. All right, so 6 o'clock, this is what we had in the state, and now at 1:30, what have we got? We've got our mental health still in Whyalla. We're going to do a rural and remote review for her, and she's possibly going to stay there. Our retrieval team, general service team, are bringing back this non-invasive patient from Port Augusta, and that's going in the rightish direction. We've got a new one in Mount Gambier and Pyema. We've got our young 3-year-old in Broken Hill with the pleural effusion. We've got our diabetic foot, ulcer and necrotic toes in Barmera. We've got our arrest, our maternal arrest in Port Lincoln. We've got our intubated ventilated GCS3 in Murray Bridge. We've got some colitis in our old chap in Mount Barker, and we've got our neonatal respiratory distress in the city, needs to move to a tertiary NICU. So that was, and then after that, things settled down and I got some sleep. So reflection on that night for me, what did we do well? What do we stop doing, start doing, those sorts of things? We've got to reinforce that we need to do the basics well, and getting those basics well means everything flows on nicely, and the depth of tube and balanced transfusion and keeping patients warm is just so important, and it gets reinforced time and time again. And with bleeding, let's find it, let's stop it, and let's replace it. I think I fell into a bit of a cognitive bias with the one in Port Lincoln. I was thinking maybe she had AFE because that explained everything, the shock, the hypoxia and the coagulopathy, but with reflection, she probably had a hemorrhagic shock, right main stem intubation, and then a dilutional consumptive coagulopathy. And it reminds us of Hickham's dictum. Couldn't telehealth with the one in Port Lincoln because they were in theatre. We've got a really nifty setup where we can dial in and have a look at patients in resus rooms and help the team out, and it's so helpful to get a look, particularly the paediatric patients that we coordinate for, just to see how sick they are. But we couldn't do that for this one. And it's on reflection in this case, it's a really important balance to try and strike, where we give some instructions to the local team, but if we give too many instructions, they'll be overwhelmed and nothing will get done, versus not giving enough instructions. And that quality of that communication is just so important. And this coordination role, where you're not putting lines in and putting tubes in, is yes, there's the clinical aspects of it, but it's just a massive communication role. And when we communicate well, things tend to go a lot better. So how has the service progressed since then? Well, it wasn't from this case, but we've been trying to get FibConc availability for a while now, and we now have it. We've got it on base, and it's in quite a few sites around Country Health in SA, and we've changed our shift structure. So we've now got an afternoon team where we used to have a third day team that didn't get used that much, and that might have actually been helpful on this night because we had that knock-on effect with team availability. This is our FibConc CPG. We carry the top one with the product, and then the bottom container holds our sort of giving stuff. Okay, so how are we going to follow up? Well, the follow-up of these patients, a 56-year-old, the Activate from just before 7. Look, he was really banged up. He had severe head injuries. He had a big flail segment, and he had a really tough and difficult hospital course, ICU, trachea, VAPS, those sorts of things. And then all the cognitive and social consequences of a severe traumatic brain injury, and he went to brain rehab afterwards. 3-year-old got her drain inserted on day 1, got removed, and it reaccumulated, and then she had a VATS assisted drain put in and clean out, and then she had a 2-week hospital stay and 6 weeks of antibiotics. The 56-year-old scan was unremarkable, and that was put down to her GCS was put down to possible polypharmacy and alcohol. And our 21-year-old, her hemodynamics and coagulation stabilised. So her scan at Flinders showed that she had a uterine pseudoaneurysm. And the note on our electronic health records from the consultant obstetrician talked about a known rare complication where the broad ligament can cause a tear, and that's probably what's happened here during the procedure, during the C-section. So she got embolisation of that and laparotomy, relook, and the PACS and back rib balloon removed. She developed renal failure, needed dialysis. She also had developed pituitary apoplexy, I guess from the hypoperfusion, but I'm not exactly sure. And she needs ongoing hormone replacement in ICU for 10 more days, hospital for a month, and then on to rehab. And you can probably understand why she doesn't want to have any more pregnancies. I hope I haven't painted Port Lincoln in a bad light. It's a wonderful place. If it's on your places to visit, then please keep it on your place. High up on the list. You can see it's a beautiful little town. You can meet some of the local fish. You can throw some of the local fish and win a prize if you throw it a long way. So please do visit Port Lincoln. That's it. Thanks for the privilege of talking today. And we've got a good job. Would love you to come join us. Questions?
Awesome. Thanks very much, Dan. Has anyone got any questions here in the room?
Great talk, Dan. And just this Carol Harbour here. Just a couple of questions for you. The first one was, you managed to give a talk in 2022 without saying the C word, and I was just wondering how's COVID affected South Australia and the way the state deals with cases, because certainly in New South Wales, we found lots of hospitals not willing to take COVID cases, meaning lots of work done to try and work out whether people have COVID. And that's all now changed with RATs and whole changes in policy. But I'm just interested in how COVID interacts with retrieval in South Australia.
Yeah, absolutely. We've probably gone through a similar evolution to other services in that initially there's a lot of panic, and they weren't going to have any COVID patient, and as soon as someone was positive, they were going to have to be transferred out immediately because they were going to contaminate the whole rural hospital and staff, and then they were trying to get that happen, but we obviously couldn't facilitate those transfers, and then people over time, we've only really had it in SA since about November, so we're still probably only 6 or 7 months of living with it, but we now getting to hopefully a bit of a steady state where we regularly ask about the RATs, and people are more willing to send home the well COVIDs, where early on, if you got COVID, gee whiz, you needed to be transferred to Adelaide for admission, whereas now we understand that if you're pretty well with it and you otherwise you're vaccinated and you don't have immunocompromised, those sorts of things, then you can probably go home, and we're happy to give advice, but that's eased the strain on people asking us to transfer them. And in terms of transferring them, again, it's gone through an evolution. I know you guys done some work, and overseas done a lot of work on what's safe for the teams to transport. Early on, we're like, well, we're going to have to tube them. We can't possibly do it on non-invasive, and it's going to be too dangerous. But now I think the evidence is that coughing and speaking and spluttering is just as much going to be aerosolizing as a good non-invasive seal. So we are moving a few. We're not moving heaps, but we would probably expect that evolution to continue. I'm not exactly sure what that will go to next, but it's certainly not the hysteria that we had initially. And we're over that phase where everyone has to move, and hopefully we're in a bit of a steady state.
Cool. So while waiting for some other questions, I thought I'll continue to dominate by asking another question. Your fibrinogen concentrate, we've been trying to get that for a long time. It's obviously very expensive. It's German. It's not TJ approved. And patient selection is the problem. I just noticed on your slide something you mentioned about ROTEM, and that you had to get ROTEM confirmation of coagulopathy before giving it, which I would have thought basically it means you can't give it to anyone, because if the hospital has ROTEM, it has cryo, and then it's. So I'm interested.
Yeah, it's been a long work by people who've been working really hard, and I want to come into it at the end. We got a bunch of COVID money for blood resources. Everyone thought everyone was going to get COVID, wouldn't be able to donate blood, so therefore would be it'd be a scarce resource. So there was a bunch of money that came in for that, and some of it was allocated to some fibrinogen concentrate, which is great. It's a really good question about the Rotum. In hospital, yes, ideally Rotum guided, and then we've been able to extrapolate that out to pre-hospital. We're probably not going to give it pre-hospital, just in terms of our current familiarity with it and timeframes, it probably won't work. But for the inter-hospital patients who have got a known coagulopathy amenable to fibrinogen concentrate, then we would usually involve the critical bleeding hematologist and give it without a Rotum guided number.
Okay, thank you for that. It's a challenging area because we really want to get pre-hospital because we think that's kind of where it'll make the difference. But yeah, it's a tough one.
Yeah, I think these patients absolutely their acute traumatic coagulopathy. I think if they can get some fibrinogen replacement on early would be amazing. We just with our transport times, I can possibly see it. We go to some metro pre-hospital jobs where the transport times are like 20, 30 minutes. I don't think we're going to have the capabilities to give it in that job. Whereas sometimes we go sort of 100 to 200 kilometres by helo to a primary, and we have 30 minutes or a touch longer in a helicopter where sometimes we're not doing a heap. And that's where we think we might be able to value add. But then we haven't quite locked in how we're going to identify those patients as having acute traumatic coagulopathy. It's still a work in progress.
Cool. And then finally, the thing I guess I got most out of your talk is that you're not only the clinical coordinator for the entire state, but also seemingly the clinical advice, telehealth support for the entire state, which is an incredibly difficult job to do both things, because you kind of, in some ways, require different mindsets and skill sets, and sometimes require simultaneous advice to two different organisations, and it's amazing that you're able to do it. I just wondered if there are other support services or other telehealth supports in South Australia, because in New South Wales we found that we just couldn't do it from one individual, even two individuals, and it had to be pushed back to the local health districts to manage most of their own advice lines within their own networks.
Yeah, we've got it's a bit of an evolving space with all of the hospital avoidance stuff that's going on. We used to have a GP run service where overnight, if the country hospitals weren't quite sure, they would do a telehealth with the CAT 345, and they would go through this GP run telehealth service, whereas the CAT 1s and CAT 2s would come to us for advice and potential transfer. And there is a bit of an evolving, it's called the Virtual Care Service. It's a SAAS and SA Health run organisation, which is doing a lot of hospital avoidance stuff with the metro city, the metro SAAS teams. And they might be doing a bit more with the rural patients, but not a heap at this stage. It's nice. I've presented this night because it was one of my worst ones. And they're not always like this, but that balance of advice and coordination can get tricky. And our own escalation pathways when we get overwhelmed are quite clear. We've got a senior second on who's one of the MRCs who's been around for a while, or either the head of unit or up to AP who is happy to call if the shit's hitting the fan.
Cool. Awesome. Yeah, no, thanks very much, Dan. Just see if there's any questions online. Just had one quick question. I don't know if I misheard, but did you, in terms of the retrieval of paediatric patients in South Australia, so you've got a NETS team, but am I right? Does MedSTAR move them as well then?
Yeah, we come under the MedSTAR banner, and the coordination, it's the neonatologist up to 28 days, us after 28 days. Whereas in terms of transporting them, it's usually the general service do the 18 and older and above, and then the kids service do the 17-year-olds and down, including the neonates. So on base at the moment, we depending on how many teams you're out, we'd have 2 kids teams, 2 adult teams. It's after 10, so we'd have the third afternoon shift there, and then depending on the age which team would get tasked.
Yeah, brilliant. No, thanks very much. All right, I'll just see. I don't think there's any more questions coming up. But yeah, Dan, I just want to say a massive thank you and extend our thanks from this end. It was a really fascinating talk. I think it was great just to see how everything's managed in a different state and the challenges you guys face. So thanks very much.
Pleasure. Thanks for having us.